Welcome everyone to this Fujita Alumni Association webinar. First of all, I want to welcome Professor Yoko Kato, our main sponsor and inspiration. And I also want to welcome our two speakers, Professor Giovanni Raffa and Professor Pridarshan. We will introduce them very soon. Thank you to our discussants today, Dr. Hari Kiran, Dr. Atiq Islam, Dr. Afzal Sharaf. And we are also very happy to have as a commentator Professor Atish Kumar, another great friend of our association. Before starting, I would like to ask Professor Kato to give some introductory words.
Thank you very much, Mr. President, Dr. Albert of our alumni. So I think our band is become very stronger now, and also that we can help each other and also teach, and maybe I think a lot of rewards to others, I think. So this is the main purpose of the Alumni Association. Thank you very much, Dr. Albert, for taking care of this association. So let's start. Thank you very much.
Thank you, Professor. And of course, I don't want to forget Dr. Liu and Raja for always helping us in organizing these webinars. So thank you, both of you. Very soon, also, my dear friend and co-moderator, Professor Ishu Bishnoi, will join. I also am very grateful to him because, you know, we share this kind of duty for the Alumni Association. So let's start with the first speaker. It's my great pleasure to introduce Professor Giovanni Raffa. Professor Raffa got his medical degree at the University of Messina in Italy, and between 2009 and 2015, after getting his degree, he attended residency program in neurosurgery at the University of Messina. During the same period, he spent several months at different academic institutions in Europe and USA, like in Virginia or the University of Cincinnati, and also at the Charité Institute in Berlin. He completed then a PhD course. His main fields of interest are neurosurgical oncology, functional neurosurgery, cognitive neuroscience, advanced preoperative planning for brain tumor surgery, based on navigated transcranial magnetic stimulation and DTI fiber tracking. Actually, his talk today will focus on this topic. He is author of more than 80 scientific papers and is member of the editorial committee of several international peer-reviewed scientific journals. From 2020 to 2023, he has been the secretary of the Young Neurosurgeon section of the Italian Society of Neurosurgery. And in 2023, last year, he has been appointed as chair of the EANS Young Neurosurgeons Committee. Today, Giovanni will talk about preoperative brain mapping and planning for function-guided surgery of brain tumors in eloquent areas. So a very important topic. It will be of great interest for not only for young neurosurgeons, I think. So thank you very much, Giovanni, for joining us. And please, you can share your screen and start your talk.
Thank you, Alberto. It's a great honor for me to be here today. And of course, I want to say thank you to you, but also especially to Professor Kato for this great honor to be with you today. So my talk will be focused on the advances planning for surgery of brain tumors located in eloquent areas. We all know that the modern strategies for this kind of surgery is to achieve the maximal safe resections. That means to remove as much tumor as possible, but also preserving the surrounding functional networks in order to reduce the occurrence of postoperative neurological deficits. And we know that the brain functioning is very complex. We know the brain is composed by different networks, and we need to map all these networks if we want to preserve them and to reduce the occurrence of postoperative neurological deficits. But of course, in brain tumor patients, it is very complex because even the presence of the brain tumor itself can induce neuroplasticity. So we should try to map these networks during surgery in order to preserve them and to achieve our maximal safe resection, for example, in glioma surgery. But today, we can do it during surgery by using intraoperative neurophysiological mapping and monitoring, but we have also novel technologies that allow us to use different tools, electrophysiological tools, neuroimaging tools, neuropsychological tools to achieve also a preoperative brain mapping to understand the relationship between the lesion and the surrounding functional network before entering the OR. So the most important tool doing this is the navigated transcranial magnetic stimulation. It is tools that merges electrophysiology, neuroimaging, and if you want also neuropsychological tools in order to achieve a preoperative mapping. If you look at these two pictures, the left one is an intraoperative neurophysiological mapping, and the right one is the preoperative mapping achieved by NTMS. There is not so difference. We have different spots that have been mapped using electrophysiology, and the results is almost the same. And we will discuss about the accuracy of this preoperative mapping that is able, today we can say it is able to anticipate intraoperative electrophysiological mapping findings, especially if we are going to map the motor network. But how it works, the NTMS is based on Faraday principle, and it is able to stimulate in a non-invasive way the cortex of our brain, and it allows for a focal manipulation of cortical activities using different stimulation paradigms. So in the end, the NTMS enables for a brain cortical mapping just before entering the NTMS. And it is also combined with the modern neuronavigation technology, so we can use the MRI scan of our patient, achieve a 3D reconstruction and rendering of the brain cortex, and then use this kind of neuro imaging reconstruction to map the cortex located close to the brain tumors in order to achieve our brain map. We can use the NTMS using two different simulation paradigms. The first one is that one that we use for model mapping. It is based on a single path stimulation that allows for the activation of the motor cortex, so we can achieve a motor evoked potential, as you can see here, exactly as we can achieve during surgery by using our gold standard direct cortical stimulation. So we can activate the motor cortex and visualize the exact location of the motor cortex on the 3D rendering of the brain MRI scan of our patient in a non-invasive way. This is the final result with a great spatial accuracy. Each single spot you can see here refers to the cortical representation of different muscle on the motor cortex. So we have the light blue spot of the tibialis anterior muscles, the blue spot that are achieved by stimulating the cortical representation of the abductor pollicis brevis. Here we have the spots regarding the orbicularis oculi, and so on. So we can achieve, before entering the OR, the somatotopic mapping of the motor cortex. But we can use NTMS also with a repetitive stimulation, try to interfere with normal cortical activity during the execution of a specific neuropsychological task. For example, this can be used for mapping language areas, exactly as we perform during 𝑘𝒄 surgery when we ask the patient to name object, and in the same time we are going to simulate the cortical areas, try to find the cortical language essential sites that we must preserve during surgery. So we can use through the NTMS a repetitive stimulation, trying to interfere with the cortical sites of the language network during a task, usually the object naming task, and this allows for the localization of the language essential sites on the cortex of our patients, and we can use all this information to preserve these spots. So probably I want to show you this provocative slide. We are moving towards a paradigm shift because we started studying the brain functioning in the 19th century using post-mortem mapping. Please let's think about 𝑃𝒂𝒏𝒂 have done in the past. And then we moved to the current era, that is the era of the intraoperative mapping, in which we use our electrophysiological tools to map different cortical areas during surgery. But probably the future will be characterized by the use of these technologies, combining electrophysiology and neuroimaging, allowing us to perform an accurate brain mapping just before entering the OR, reducing also the time needed in the OR for intraoperative neurophysiological mapping. But of course, before thinking about a future era in which we can use only NTMS for brain mapping, we should talk about the accuracy of this kind of technology. And I want to show some literature evidence about the accuracy of NTMS for motor mapping. This is a systematic review published in 2021 that compared the NTMS and the other important techniques that we can use for preoperative mapping, that is functional MRI. And this review analyzed the accuracy of these two technologies as compared to the gold standard, that is the direct cortical stimulation. And as you can see, the review concluded that the NTMS mapping has a higher spatial accuracy than functional MRI. So the results for NTMS are closer to those of the direct cortical stimulation as compared to functional MRI. And this is very important for us because this allows to stratify our patients just before entering the OR, and it is important to understand which is the risk of developing postoperative neurological deficits and the possibilities that we have to achieve our maximal safe resection during surgery. And we can know all this information just before entering the OR, and we can use this information to plan our surgery. So these are two cases, two high-grade gliomas located in the right hemisphere, close to the motor cortex. If we look at the contralateral hemisphere, the unknown sign, the omega sign, is corresponded to the location of the lesion. Probably this one on the left is a little bit more posterior. The second one is a little bit more anterior. But if we want to know exactly the relationship between the motor cortex and the lesion, we have to do our NTMS mapping. As you can say, the result was completely different in these two cases, because in the first cases, the lesion was posterior to the motor cortex, so resection of this lesion is not so risky. While in the second case, the lesion was, or the motor cortex was just overlapped to the lesion. So it's clear that this kind of lesion is a lesion at high risk for developing postoperative neurological deficits. So a gross total resection probably is not achievable, while in this case, on the left, the probability to achieve a maximal safe resection, a gross total resection of the lesion is very high. So this lesion has a lower risk for developing postoperative deficits. And again, these are other this is another case, sorry. This is probably the omega sign. So on the right hemisphere, the lesion seems to involve the motor cortex. But when we perform the NTMS-based motor mapping, you can see the lesion was closed, but was not infiltrating the motor cortex. So in this case, the risk for developing postoperative neurological deficits was intermediate. And this is a similar case. Again, probably this is the omega sign, the lesion is anterior, but in the end, after our NTMS mapping, you can see that the lesion was overlapped by the NTMS spot of the motor cortical representation of the orbicularis oris and orbicularis oculi. So in this case, the achievement of gross total resection is absolutely risky because of the overlapping between the motor cortex and the lesion, which is infiltrating the motor cortex. But of course, NTMS is not enough because NTMS provide only cortical information. We should know also the organization of subcortical pathway if we want to achieve our maximal self-resection and reduce the occurrence of postoperative neurological deficits. So in 2014, we published this paper on operative neurosurgery, in which we proposed the use of the NTMS motor mapping as seeding region for the DTI tractography of the corticospinal tract. By using this technology, we were able to use this functional information provided by the NTMS, that is the motor mapping of the motor cortex, as seeding region for the final reconstruction of the corticospinal tract that can be reconstructed with its somatotopic representation, so we can distinguish between fibers originating from the representation area of the leg muscle in the motor cortex, the fibers coming from the representation of the arm muscles, and the fibers of the corticospinal tract originating from the face representation of the corticospinal tract. This can allow us to achieve a more accurate reconstruction of the corticospinal tract using tractography as compared to the standard technique used for DTI tractography, that is based on the selection of anatomical areas as a seeding region for the computation of the corticospinal tract. And this reconstruction can be used also during surgery. And we demonstrated that the use of this kind of information also during surgery for guiding direct electrical stimulation is very helpful, and it is associated also with an increased extent of resection and an improved neurological outcome in patients with motor eloquent lesion as compared to standard surgery using standard DTI tractography. I want to show you some examples. This is another lesion. This is in red is the omega sign. The lesion seems to be very anterior, but if we look in the sagittal plane, this is the Rolandic sulcus. So the deeper portion of the lesion goes back and probably is in contact with the corticospinal tract. This is another case, recurrent GBM. This is the omega sign, and probably the lesion is involved in the motor cortex. Let's see what happened when we perform our NTMS-based mapping and planning. According to the standard MRI scanner, we should say that both lesions are at high risk for developing postoperative neurological deficits. But when we perform our mapping and planning with the 3D reconstruction of the relationship between the tumor and the motor network, the results were quite different, because in the first case, as you can see, the leg fibers of the corticospinal tract are just displaced, not infiltrated. But in the second case, you can see here, the same fibers are completely infiltrated by the tumor. So it's clear that both cases are at high risk, but in the first case, the possibility to achieve our maximal self-resection is higher as compared to the second case, in which we know before entering in the UR that probably we cannot resect all the tumor because it infiltrates the corticospinal tract. So if we want to achieve our maximal self-resection, reducing the occurrence of postoperative motor deficit, we should perform a partial resection. So we know all these by performing our NTMS-based planning just before entering in the OR. So we had a clear idea about what we can do during surgery. And let's talk also about the clinical efficacy of this kind of mapping and planning. This is a systematic review that we performed in 2019, comparing different papers, analyzing the role of this kind of NTMS-based mapping and planning for motor eloquent lesion. And as you can see, the final result was that this kind of preparative brain mapping and planning significantly reduced the occurrence of new postoperative permanent motor deficits as compared to standard surgery without preoperative NTMS-based mapping and planning. And as well, this kind of preoperative brain mapping significantly increases the gross total resection rate in these patients as compared to standard surgery without using the NTMS-based mapping and planning. And move on talking about the ability of NTMS to map the language areas, because in this case, the mapping of cortical language areas is more complex than mapping of the motor cortex. So there is a difficult interpretation of evidence from literature because there are also less papers on this topic. Anyway, I want to come back again to the same review of the published on 2021, in which you can see several papers reported several different accuracy, because sensitivity and specificity varied along different studies. But I want to underline especially the high value of this parameter, that is the negative predictive value, that was ranging in different studies from 57 to 100%. This is another study published in 2022 from colleagues working at the MD Anderson Cancer Center in the USA, comparing again the accuracy of NTMS versus functional MRI for language mapping in comparison to the standard direct cortical stimulation. And if you look at this table, NTMS has sensitivity, specificity that is higher as compared to functional MRI. And again, the negative predictive value is very high, 99%. This is another study published on Journal Neurosurgery in 2021 by the colleagues of Berlin, Germany, in which they found that the NTMS language mapping is very accurate in identifying the true negative language spots. The accuracy in the detection of true positive is instead low. But if you think on this milestone paper published by Sanai et al. In 2018, in which he described the so-called negative language mapping, you can see that the two images are not so different. So the NTMS is very accurate in detecting especially the negative language sites in the cortex. So if we base our resection on negative mapping during surgery, we can base our resection also on negative mapping by NTMS before entering the OR, because the accuracy of the NTMS for mapping of the language areas is similar to that of the intraoperative electrophysiological mapping regarding negative sites. So we can try to increase the accuracy in detecting also positive language sites by changing the task during the NTMS repetitive stimulation. For example, changing from an object naming task to an action naming task that is able to increase the accuracy of the technique in detecting true positive language areas that must be preserved during our surgery. And again, even in the case of language mapping, we need to have some information regarding subcortical pathways. And of course, again, is it it is possible to use the NTMS language mapping a seeding region for the reconstruction using tractography of the main subcortical language tracts, like the arcuate fascicle, the inferior fronto-occipital fascicle, uncinate fascicle, and so on. This is a paper that we published in 2020 that showed that our reconstruction using the NTMS language mapping as seeding region for the reconstruction of language fascicle was very accurate. And this kind of reconstruction is also useful for the stratification of patients because, for example, patients in which the tumor is located at a distance of 16 millimeters or lower from the arcuate fascicle or 25 millimeters or lower from the other language-related tract is at high risk for the occurrence of surgery-related aphasia. So again, even the NTMS-based reconstruction of the language network is useful for the stratification of patients and predict the occurrence, the risk for the occurrence of postoperative language deficit. This was confirmed also by this paper that we published in 2018, in which we demonstrated that the NTMS language mapping can reliably predict the occurrence of postoperative language deficits. And so in the end, all this information provided by the NTMS preparative mapping can be used for three objectives. The first one is to plan the best surgical strategy for achieving the maximum safe resection of the lesion. This is the case of the left temporal glioblastoma surrounded by the white spots that are the NTMS spots of the language mapping that is combined with the DTI tractography with the main language fascicle. And by doing so, just before entering the OR, we can try to plan our best surgical strategy. But all this information can be used also to stratify the risk of developing postoperative deficits, motor or language deficits, by simply measuring the distance between the fascicle. In this case, this is the ascending segment of the arcuate fascicle that is close to the lesion, or in this case, this is the uncinate fascicle that is close to this left frontal low-grade glioma. So we can measure the distance and predict the risk for the occurrence of postoperative motor and language deficits. And all this information can also be used during surgery to make intraoperative mapping faster, quicker, and also safer, allowing us to improve the resection of our lesion and to achieve our maximal safe resection. So after showing to you what is the usefulness of the NTMS-based preoperative mapping and planning, I want to show you what we do currently in our clinical practice, which is the workflow that we use whenever we have to deal with a patient affected by a brain tumor located close to the language motor network or even the visuospatial network. Of course, after the identification of patient with this kind of lesion, we performed our assessment of functional neuroanatomy through the NTMS preoperative mapping and planning. According to the results of the NTMS preoperative mapping, we decide if the patient should undergo a WEG surgery or not. And according to this indication, we perform our ASLIP surgery, in which resection is guided entirely by the NTMS-based planning, or, of course, we can perform the WEG surgery, which we use intraoperative electrical stimulation, but we use also the information provided by the NTMS that are implemented into the neuronavigation system and guide us during resection, during intraoperative mapping, and trying to help us in achieving the maximum safe resection. This is our series, more than 440 patients affected by different kinds of tumors, even some vascular malformation. But of course, the most patients were affected by high-grade gliomas. And I want to show some cases. This is a case of 55 years old male with presenting with the left facial brachial hemiparesis. the lesion probably involved the right motor cortex, and we performed our NTMS mapping. As you can see, in the end, the lesion is close but does not infiltrate the motor cortex. So a gross total resection is possible, and especially because even when we perform the reconstruction of the corticospinal tract, we observe a safe distance between the lesion and the corticospinal tract. And that is what we have done during surgery. Of course, we performed our intraoperative mapping and monitoring, but this step was quicker just because we already know where the motor cortex was located and where the corticospinal tract was located. So mapping was easier, was faster, and in the end, the intraoperative cortical mapping confirmed what we achieved before surgery using the NTMS mapping. And after verification using intraoperative direct electrical stimulation, we started, of course, with the tumor debulking and resection, and this is the final result with the gross total resection of the lesion, and no postoperative neurological deficits were observed. This is another case. This is a language eloquent glioblastoma in the left temporal lobe. Young female, 47-year-old, with a mild sensory aphasia. This is the NTMS language mapping showing that the NTMS positive spots were surrounding the lesion, but were not overlapped to the lesion. This is a good news because it means that we can go through the lesion, try to resect it, and this is to treat the reconstruction, the relationship between the lesion and the entire language network, NTMS cortical spot plus the subcortical tractography reconstruction. Again, this is a detail of the relationship between the lesion and each single language fascicle, starting from the arcuate fascicle, uncinate fascicle, up to the IFOF and the ILF. Of course, we perform a weight surgery, and we use this information to perform small craniotomy, locate easily the lesion, and make our aortic surgery shorter. That is more comfortable for patients and of course also for the surgeons. This is the final result with the complete resection of the lesion, no postoperative language deficit. But we have to consider that in many cases, awake surgery is not feasible. Indeed, we have a big elephant in the room because there are many patients who are not eligible for awake surgery. That is the gold standard. For example, children, older patients who are not collaborative during surgery, patients affected by psychiatric disorders, including anxiety, cases in which there is a difficult management of airways, or even patients who refuse to undergo awake surgery. So in all these cases, whenever we deal with a language eloquent lesion and awake surgery is not possible, NTMS preoperative mapping become very useful because provide us with the information about the relationship between the tumor and the language network. So we can use all this information to guide our surgery. For example, NTMS language mapping is feasible also in children that usually are not easily submitted to awake surgery. We had many experience on that. And I want to show some cases in which awake surgery was not available, because the patient was not eligible to awake surgery. And we performed our NTMS mapping and planning of the language network. Like in this case, a lesion of the left temporoparietal occipital junction. The lesion was very close to the language network, especially to the arcuate fascicle, to the ascending ramus of the arcuate fascicle in orange. And we use this information to guide the resection of the lesion during a sleep surgery. So in this case, wake surgery was not performed. And this is the postoperative results in which the lesion was completely removed and the ascending ramus of the arcuate fascicle was preserved. And as well as also the other fascicles of the language network were preserved. So in the end, the resection was gross total, and the patients operated during a sleep surgery did not develop any postoperative language deficit. This is another case, left temporal glioblastoma. The patient was a female, 61 years old, not eligible for awake surgery. The NTMS cortical mapping showed the NTMS language spots were posterior and superior to the lesion, but they were not overlapped to the lesion, so a gross total resection was planned. This is the reconstruction of the network with some spots over, some spots behind the lesion. But that was a slight infiltration of the uncinate fascicle that is depicted in pink. This is the postoperative MRI scan. The patient developed an anomia. This is because, as you can see here, the uncinate fascicle was infiltrated by the lesion, and we were not able in this case, in this specific case, to preserve these fascicles. So we had a postoperative anomia, but no other language deficit. We therefore decided to analyze our series and publish it in 2022, analyzing the impact of the NTMS-based mapping and planning of language network in a series of 176 patients, analyzing the extent of resection and the postoperative outcome. And as you can see, we achieved an occurrence of postoperative permanent deficits in 7.3% of cases. It is slightly superior to the percentage that is reported using awake surgery. But remember that these are patients who are not eligible for awake surgery. So the resection was entirely guided by the NTMS-based preoperative mapping, and the gross total resection was 80%. So in our opinion, these were good results, and they were not so far from what is reported in the literature regarding awake surgery. And finally, I want to also show you how the NTMS can be used for mapping the visuospatial network. Because on the NTMS system, some specific tests for the examination of the visual spatial abilities can be implemented, like the Hubert test or the line bisection test. And these tests can be used during repetitive stimulation. So like we perform during language mapping, we can try to interfere with the visuospatial network using our NTMS repetitive stimulation while performing a specific task that is able to investigate the visuospatial activities. And we can also perform NTMS-based tractography of the main fascicle involved in the visuospatial network, which is the superior longitudinal fascicle and its three branches, SLF 1, 2, and 3. And this is an example of one patient which we performed our mapping. In orange, you can see the superior longitudinal fascicle, which is displaced downward by the tumor. And we had a preliminary experience in mapping this kind of network in 20 patients, and we observed that we had an improved postoperative visuospatial outcome by using the NTMS preoperative mapping and planning as compared to patients that were operated without using any kind of NTMS preoperative mapping. So we were very happy about these results. And finally, I want to show how the NTMS mapping of eloquent networks can be useful also for reaching out deep lesions. In this case, are not gliomas, but we are talking mainly of meningiomas, but they are located deeply. And in all these cases, the most important concern is to reach a lesion without passing through the eloquent networks. So to do so, we should map these networks and doing like in the minefield game in which we reconstruct our eloquent network, the language network, for example, for a lesion located in the left hemisphere, and then we should find a trajectory to reach the deep-seated lesion without passing through these networks. And to do so, we also combine the NTMS preoperative planning with the use of tubular retractors that can be used to displace white matter fibers and allow a safer trajectory from the cortical surface to the lesion that is located very deep in the brain, for example, inside the ventricular system. And I want to show some cases, the case of a very large meningioma located inside the left trigone. This is the NTMS-based preoperative planning. In green, you can see the optical radiation, the optic radiations. Here in orange, you can see the arcuate fascicle. So we, after the NTMS preoperative planning, we decide to have a trajectory that aimed to pass between the arcuate fascicle and the optic radiation. This is the planning I want to show you. This is the lesion, very big. The optic radiation is lateral to surrounding laterally the tumor, as you can see, and is passing just lateral to the most inferior portion of the lesion, while the arcuate fascicle was surrounding the posterior and superior portion of the tumor. So we decided to follow a trajectory between the optical radiation and the arcuate fascicle. I want to show you here. This is the one is the trajectory trying to reach a lesion without passing through the main fiber bundles of the language fascicle. This is what we had done intraoperatively, in which we placed our tubular retractor using the navigation system guidance. And of course, we reached the meningioma. We resected this big meningioma. This is the final result. This is the trajectory of the tubular retractor. But most important thing is that if we look at the postoperative NTMS-based plan, you can see here, this is the trajectory of the tubular retractor that is passing through the optic radiation, but this trajectory is just displacing the optic radiation fibers without interrupting them. So as you can see here, even the ILF, the fibers of the ILF in pink and of the IFOF in light blue were displaced. The patient did not had any kind of postoperative visual deficit. This is another case, smaller meningioma of the left trigone. Again, we planned our surgical trajectory based on the NTMS planning. A lateral approach was not possible because the trigone was covered by the optical radiation, of course, the arcuate fascicle and the ILF. So we tried to find a trajectory that was from posterior, from the occipital lobe. So the yellow one is the trajectory that we plan to achieve the lesion without crossing the main fiber bundles of the optic radiations, arcuate fascicles, and all the language-related fascicle. And this is what happened inside the operating room. The tubular retractor was inserted under the guidance of the neuronavigation, trying to respect the main white matter fascicles, reaching the lesion, starting resection, of course, and verification using the navigation system, the relationship between the fascicles and the lesion. And then the lesion, of course, was resected. we performed again postoperative DTI showing no interruption of the main subcortical fascicle and no postoperative visual nor language deficit. So again, I'm going to my conclusion. Probably I want to show again this slide saying that probably preoperative mapping can be really helpful in the future. It is already helpful, especially in patients in which we cannot perform intraoperative direct electrical stimulation, like I showed to you in patients not eligible for awake surgery and affected by language eloquent tumors. But probably in the future, we will use even more this kind of technology, because it allows for a reliable identification of the motor, language, and visuospatial networks. It is able to provide a reliable preoperative stratification of surgical risk, and is very helpful for the intraoperative verification of the networks that must be preserved, making intraoperative direct cortical and subcortical stimulation easier and faster. And in many cases, the use of this kind of preoperative mapping together with the intraoperative mapping improve the postoperative functional outcome, at least for lesion located close to the motor network. So I concluded with my talk, but before concluding, I want to invite you all to the next Third World Young Neurosurgeon Congress that the ACNS and the ENS are jointly organizing in Sofia, Bulgaria, on 12-14 October 2024. So we will be happy to see you all also there to join us in this global event that we organize thanks to the ideas of Professor Cato and Professor Andrea Demetriades, and with the support, of course, also of me and Ben. So thank you.
Thank you, Giovanni, for the very nice presentation. We enjoyed a lot, and I think we also learned a lot from your presentation. Before discussing your presentation, I want to welcome Ishu Bishnoi, who joined us. Hello, Ishu. And I would like to ask Professor Ashish Kumar to give his comment on this presentation. Please, Ashish.
Thank you so much, Alberto. It was a great talk, Professor Giovanni. I mean, I've read about like neocortical transmagnetic stimulation, but we don't use it often in our practice. But I wanted to, just ask about how this all developed. Like, what were the initial, pilot studies which you did in your patients, and realized that okay, these are the patients where I'll not use it, or these are the patients I will use it. And based on before your, actual studies, were there any kind of roadblocks in assessing on using this technology in GBM patients? Because the challenge which I face most often are that we are using, especially for higher cognitive functions, is that these patients sometimes are not fully cognitively intact. So especially when you are looking at visual functions or language mappings, especially in the sensory specifics, it becomes very challenging if suppose these are also having these patients are having preoperative cognitive deficits. So how did you navigate your initial recruitment for the studies with these patients with certain challenges?
But of course, you're right. The presence of a cognitive deficits or language deficits or even a motor deficits is a major drawback of this technology, because if the patient cannot perform the task during mapping, the final results are not so good. So this is a common limitation, but it is a limitation of the also for intraoperative direct cortical stimulation. If we're doing a wax surgery and the patient is not cooperating because she has a cognitive decline, you will have some troubles. So this is a common drawbacks of all the technologies using electrophysiological mapping, because you need the cooperation of the patients, and you need the neurological deficits are not so bad. It's clear that I can do a model mapping in a patient with a hemiparesis, but I cannot do it in a patient with an hemiplegia. And it is the same thing that you can find in intraoperative in the OR when you do your direct electrical stimulation. So this is a limitation of the technology, of course. But of course, in our studies, we selected all patients without severe neurological deficits, especially because our objective was to preserve the neurological performance. If the patient has already severe deficits, it's difficult to come back after surgical resection. If you have a patient with mild motor deficits, mild language deficits, your objective should be to resect the lesion, preserving the residual motor or language function.
Thank you so much. And who does this transcranial magnetic stimulation? The surgeon himself is there when it's done, or it's done by
the surgeon? In our institution, the surgeon perform the NTMS, perform also D2 arthrography, so he studies very well the patients. So there are no surprises in the operating room. When we arrive in the operating room, we know exactly what we should do and what we can do according to the NTMS preoperative mapping.
Thank you so much. Few more questions. Do you think there are some lesions which are not suitable? For example, is there a particular size limits? Because we saw that, those infiltrative gliomas which are, involving multiple regions, like for example, frontoparietal cortex, and based on size, is there any contraindication, or is there any area where lesion which you will not attempt TMS?
I will say no. The size is not a limitation. What is important is the degree of infiltration of the network. You can perform your mapping before entering the OR. You can try to understand which is the relationship of between the tumor and the network. Even if the tumor is 5 centimeters, 6 centimeters, it doesn't matter. Of course, if you find that the tumor is infiltrating the network, it's difficult to remove all the tumors. So in those cases, we perform just a partial resection, try to avoid worsening of the neurological deficits of the patient after surgery.
Thank you. Any concerns or any usage in low-grade gliomas, especially insular gliomas? Like, I mean, that is something which is still an enigma for us, like in terms of how much you can resect and what stage you stop so that you don't cause any major neurological deficits. And it's hard to, functionally test the region where you are at that point in time.
Yes, this kind of mapping can be used for surgery of insular gliomas, but in the case of insular gliomas, it's most important to understand the relationship, for example, with the corticospinal tract and with the inferior frontooccipital fascicle if you are on the left. But consider that in insular glioma surgery, the occurrence of postoperative deficits is mostly related to vascular damage, so to the interruption of perforators, for example, not to the interruption of fascicles or cortical functional areas. So this is the most difficult aspect of insular glioma surgery. Respecting the perforator can be really difficult and complex, and it cannot be predicted by the NTMS brain mapping.
So basically, this is where we'll not attempt even preoperative mapping, isn't it? In low-grade gliomas, insular gliomas, actually.
we perform also in low-grade gliomas and also in insular gliomas. But for insular gliomas, the higher risk is the interruption of perforators instead of the interruption of subcortical white matter pathway or cortical areas or cortical function areas.
Okay. Okay.
But
Thank
it
you
can
so
be.
much. It can be done. Yeah.
Yeah.
And any difference in involvement of these in the fascicles, especially if you are doing a low-grade glioma surgery? I mean, in high-grade glioma, you have a very clear margin of contrast enhancement, and you can see. And sometimes you can make that out in during the surgery too. But in low-grade gliomas, do you think there is, there are areas which are like borderline or gray zones where you don't know, it's a tumor or it's a normal brain, and will it help there?
In low-grade gliomas, it's easier to see a reorganization of cortical areas because, of course, they are slow-growing tumors. So neuroplasticity is very high in these patients, so we can have a different location of cortical functional areas in comparison to what you can expect, but because of neuroplasticity. Concerning white matter tracts, it depends because in many cases, white matter tracts are just displaced, but in some other case, they are infiltrated. So, there are different growth pattern of low-grade gliomas. Those with a mass growing pattern tend to displace the tracts. The other one tend to infiltrate the tracts. So in those cases, it's difficult to resect the lesion without inducing a postoperative deficit.
Thank you. And you were using fluorescein and based resections as well. Do you use that for all glioblastomas?
We use a lot of fluorescein guided resection for high-grade gliomas.
Okay.
Yeah.
Perfect. I think combination of all these for young neurosurgeons actually will especially eloquent areas will reduce their risk of any postoperative deficits. As we saw in your paper, there were hardly 2 out of 85 patients who had a new postoperative deficits around that. Thank you so much. It was a pleasure, attending to this talk, and it was quite a revelation. Thank you.
Thank you.
Thank you, Ashish, for your comments. I see also Ben and Dilshad want to ask questions. Ben?
Yes, thank you. And congratulations, Giovanni, on your results. And it's a pleasure to have you here to present your results. And I'm really glad to see you here. So, and very interesting use of the navigational TMS. And I would like to ask from a user's point of view. So do you think that the whole system is user-friendly? And as you mentioned, that the surgeon might need to do the navigational TMS before the operation for the patient. So usually, how long will it take? Will it be very difficult to do all the small points as shown in the MRI? And concerning so if you have the preoperative planning in mind, so how much time you think it will reduce the time of intraoperative monitoring? Would you think you can map the patient's brain much faster with that plan in mind? Usually, how much? And that's my first question. My second question is about because in TMS sometimes there is the threshold for stimulating the patients. So is there any correlation between that threshold and also the intra-op stimulation threshold in your experience? That would be interesting to know. And thank you so much, Giovanni.
Thank you, Ben, for your question. So the first question, I personally performed the NTMS mapping. It lasts about 10 minutes for motor mapping, half an hour, 30 minutes for language mapping, but of course it's not mandatory. A neurophysiology technician can do it for you. It's not mandatory, of course. I prefer to do it by myself, so I can be really aware of the case that I'm going to operate in the successive days. And once we have our planning, we use during surgery, and it reduces the time we need to locate the motor cortex or the language cortical areas. So we perform this kind of mapping especially because it helps us in reducing time of the awake surgery, for example, because awake surgery is very stressful for the patient and also for surgeons. So by doing our preoperative brain mapping, we can be faster. We can be less invasive because we can perform also smaller craniotomy, because we are sure where the motor cortex or the language cortical areas are. So there's no need to make a bigger craniotomy, for example. So these make the surgical resection easier and faster. And of course, regarding the threshold, it's clear that if you find a low threshold during NTMS mapping, probably you will have a low threshold also during intraoperative electric stimulation. And for motor eloquent lesion, when you find a preoperative low threshold, there is a higher risk of intraoperative induced by electrical stimulation seizures. So the risk of intraoperative seizure, especially if you are doing awake surgery, can be higher. But consider also that all these patients usually take antiepileptic drugs. So it's not common to find patients with a low threshold. Because even if they had a low motor threshold before entering your department, then they will take antiepileptic drugs, so this can increase the threshold. When you are going to do the mapping, you will find a normal or an increased threshold.
I see. So in those patients with pre-existing hemiparesis or even hemiplegia, so it would be very hard to map them. Is that the case also in NTMS?
So if there is a complete hemiplegia, it's impossible to map the motor cortex because you stimulate, you cannot achieve any kind of motor evoked potential. But these cases are rare. Even if you have a severe hemiparesis, you can achieve a response by increasing the intensity of stimulation. So the number of patients who are not eligible for NTMS motor mapping is very low. In my experience, you have seen we have mapped more than 400 patients. Only a few patients were not eligible to perform accurate motor mapping.
I see. Thank you so much. And seems it's a very effective, interesting tools that we should consider. Thank you so much.
You're welcome, Ben.
Dilshad?
Yes. Thank you so much, Dr. Giovanni, for a very interesting and productive presentation. Actually, this is very interesting to use and combine these useful methods all together.
Dilshad, maybe you can introduce yourself, please.
My name is 𝒂𝒂𝒏𝒊𝒚 𝑑𝒂𝒏𝒊𝒚. I'm from Uzbekistan. I'm neurosurgeon in the Republican Center of Neurosurgery in Tashkent, capital city. I am a past fellow of Fujita Health University, Bantene hospitals, like the others. So nice to meet you, and nice to meet you all, Professor Cato, Alberto, and everybody. So I'm also interested in this field and doing for the last couple of years awake surgeries. And as you said, we also focused on direct electrical stimulation mapping. But for the last years, we also using TMS, but I'm not sure it is navigated TMS, but we're not very much developed in the TMS investigations. So I was just, my question is more focused on the technical aspect of the usage of TMS. So when you showed the slides where the TMS, the spots you found on the motor cortex or sensory cortex or the other eloquent areas, you integrated it to the brain MRI images and then used into the neuronavigation system brain lab, right? Or there is another program that you use for TMS, so and then you integrate it all together. How do you use this system, and how the accuracy was established during the TMS stimulation? Because when I saw the TMS probe surface is very large, and how do you find the accurate sites of the limb, like finger, nose, head, neck areas like this? So this is the question.
Okay, so first of all, it's a pleasure for me to meet you, and I'm happy to hear that you are interested in TMS. Regarding the first question, I have an NTMS system in which the software, after stimulation, gives to me the DICOM images with the NTMS spot already merged on it. So I take the image, the DICOM images with the NTMS spots and put them into the neural navigation system. There is no other software. Of course, there could be different NTMS system produced by different companies, but I think the most of them are doing the same thing. So they give to you the DICOM with the NTMS spot already merged. Concerning the second question, the limits of the mapped area depends on the response that you have, because you are doing a electrophysiological mapping. So each single spot is a motor evoked potential. The size of the area depends on the cortical areas, on the size of the cortical areas that you can stimulate and still record a motor evoked potential. So the limitation, the limits of the area will be reached once you have several NTMS spots in which you are stimulating, but you cannot record any kind of motor evoked potential. That's the limit.
Okay, thank you.
Thank you. And Dr. Atiq?
Yeah, thank you, dear Źvoni, for your presentation. I think it will create new insight among the awareness around the world, how to preserve the eloquent area of brain. And regarding TMS, it is new for us. In our country, we usually perform X-ray anatomy, we do neuro navigation or fluorescent dye technique, and sometimes we, in most of the cases, we perform tractography, that is TTI. But the interesting thing of your presentation is that it can help those patients in whose patients we cannot perform X-ray anatomy. We can use TMS tractography, and it can help to operate safely, to preserve the eloquent area of the brain. One simple question: do you feel that there could be any mismatch because we are performing preoperative TMS and intraoperative cortical mapping? Is there any scope of mismatch after opening the dura because of the minimal shift of the brain? Any scope of mismatch?
Of course, you're right. Brain shift is a limitation in all those cases in which you use a preoperative imaging. So if you want to overcome this drawback, you should have an intraoperative MRI scan, and you know they are not so common all around the world. So the maximum accuracy is when you open the dura, of course. But when you start your resection, especially if you go resecting the most deep portion of the tumors, the brain shift affects your navigation. That's clear. And this is a big limitation of the technique. But if we are dealing with patients who are not eligible for a WEX surgery, you can try to perform your language mapping just after opening the dura. So you can also put letters on the brain cortical areas and even at a subcortical level, and then continue working. So you can bear in mind where are the eloquent structures that you need to preserve during resection, even if at the latest stage of surgery, the brain shift occurs and the accuracy of your navigation is very low. You can help yourself by putting some letters just before starting resection. So letters will stay there, and you can still use them while resecting the lesion, even if there is a big brain shift.
Yeah, thank you. Thank you so much.
You're welcome.
Afzal?
Hello, greetings to Professor Castro, greetings to everyone present. Hello, Professor Giovanni, thank you for the wonderful talk. My question is related to Atik's previous question. So to overcome this brain shift, intraoperative brain shift, do you actually use some 𝑑𝒓𝒊𝒂, or do you think it might be of advantage if you use 𝑑𝒓𝒂 in that case? That's my question.
Okay, 5LA can be used, but of course it has a higher cost than fluorescein. But 5LA is inside the tumor cells and not inside the healthy surrounding white matter tracts or cortical areas. So it can help to increase the extent of resection, but it does not give any information regarding the functional boundaries of your resection.
Thank you. If there are no other questions from the audience, I would like to thank Giovanni Raffa for the wonderful talk and also for the very nice discussion we had, which is actually the sign that the topic raised much interest. So thank you very much, Giovanni.
It was a pleasure for me.
Thank you so much. And of course, thank you also for the invitation to attend the World Young Neurosurgeon Congress. If you can stay with us, you are welcome, but I know you have also some family obligations, so I understand it. And we can move on to the next speaker. I kindly ask my dear friend, Professor Ishu Bishnoi, to introduce the next speaker.
Thank you, dear Alberto. And thank you very much, Professor Giovanni Raffa, for such wonderful talk. I really liked it, but there were so many questions, so I have not asked my questions, but later on I will ask you on email. Okay, so I'm now inviting our next speaker, Dr. Priyadarshan KP. Today he will be talking about endoscopic membranectomy for chronic subdural hematoma. He did his neurosurgery from Madras Medical College, and currently he is working as assistant professor. And he has special interest in pediatric neurosurgery, fetal neurosurgery, neurovascular surgery. And this topic is a different kind of topic. Usually we do burr hole evacuation of chronic subdural hematoma. So it will be a learning experience to find out the scope of endoscopic membranectomy for chronic subdural hematoma. Kindly present your presentation, Dr. Priyadarshan.
Thank you, Dr. Vishnu, and thank you for having me and giving me this opportunity for sharing my experience here. And I'll just share my screen. Yes.
Sarthi, we are seeing the other slide also. Can you make it?
I think it is the presenter mode. Yeah.
Other mode.
Yeah.
We are seeing
the topic I'm bringing to you is the
on sides.
Hello, sir.
We can see the comments and the next slide besides your slides.
It's in the presentation mode.
Sir.
It's in a presentation mode, Dr. Priyadarshan. So.
Yeah, just 1 second. Is this better now, sir?
You have to share it again. Okay.
Yeah.
Yes, thank you for having me, sir. And my topic would be endoscopic membranectomy in chronic subdural hematoma. Just before going into our experience, just a brief introduction about chronic subdural hematoma. Generally occurs in the elderly and as it's one of the most common operated upon neurosurgical conditions, and most of them have a trivial trauma history. And the bleed, as given in the literature, occurs within the dural border cells. And all the symptoms and symptomatology that occur are a complication of the bleed within this border cell. And the common presentation with chronic STH is usually because of herniation to the opposite side and raised ICP features like altered sensorium on contralateral limb weakness. And occasionally, but even before your raised ICP changes and midline shifts, they can present to you with memory disturbances, confusion, and occasionally seizures also. Now, and once a patient presents, any institute is going to go ahead with an imaging. And commonly, what we routinely do is the patient undergoes a CT. And there have been systems to grade or classify these chronic subdural hematomas in an attempt to identify risk factors for recurrence. Now, this classification was brought by Dr. Nakaguchi and team in 2003. And they classified it as homogeneous hypodense chronic STHs, laminar and layered and trabecular types. This is the classical homogeneous hypodense chronic STH. The classical motor oil, when we operate and evacuate, what we find is the classical motor oil fluid, and mostly it just requires a burhole and evacuation. And occasionally, like we see here, you can see that the cortex is slightly tented up as it's held in position. In this patient, there was actually a flimsy septation that needed to be broken off to allow proper expansion. Now, this is a laminar type of chronic STH. You can see a hyperintensity along the cortical surface. Usually, these patients tend to have a recent trauma history, and this is probably a bleed along the mild acute bleed along the surface. And these patients also tend to have a small, compared to the homogeneous hypodense type, the inner membrane is not that prominent when we operate, and it becomes slightly more visible and thicker in the laminar type. And this is the gradient type of chronic STH. We have varying stages of varying age of the blood inside. Now you have a hypodense area here, and which gradually becomes hyperdense. And generally, no septations are there, but they do start to have, again, compared to hypodense variants, they start to have a slightly thicker membrane along the surface. And this is the separated variant. You can see a distinct separation between two different intensities of blood. Again, these also, compared to the hypodense homogeneous type, tend to have a membrane, and you can see some septations also within. Now, this is the trabecular variant. Generally have thick septations with thick membranes also. And here, if you, I'm not sure if it's that clear, but you can see that the membrane is actually visible even in the plain CT of such poor resolution. It's quite thick, and you have a lot of septations that's holding up the cortex here and there, and with multiple mixed density septations and cavities. Now, the point of this classification was to identify risk factors for your recurrence, but I just brought two review articles that looked upon these references. Again, both these articles included studies with extremely heterogeneous type of techniques of evacuation. Most of them were burr-hole craniotomies, and none of them included. In this first study, they did not include any membranectomy. Second studies limited membranectomy. Some investigators just made incisions on the inner membrane. After removing the outer membrane, they just made incisions on the inner membrane. Now, it's difficult to reach a consensus based on these articles, but you can notice a trend here. Generally, the recurrence rates tend to be in the double digits. Now, again, interest grew in identifying if there's a type of membrane that causes increased recurrence. There was a histological classification, but it did not gain any weight and popularity. And because most centers do not take a biopsy also. And having stated these, I'll just go into the management options that is generally available. Most institutes practice a burr-hole evacuation with adequate irrigation, and most of the times it will be sufficient. Even 1 year back, I was doing that only, but we started noticing that a particular section of people, even though you have evacuated thoroughly and your irrigation becomes completely clear, there is absolutely no blood, you don't see the brain expansion as you would hope for, and still mass effect is there. And in these patients, we had to go and do a craniotomy and revisions, and if membrane is there, we do membranectomies. Again, there are a lot of studies where they've considered outer versus inner membranectomy. Just most of the studies, they've done a craniotomy, remove the outer membrane, they leave the inner membrane, they wash out the chronic stage contents, remove the septations, they leave the inner membrane intact. We'll be discussing that in the coming slides. And in the last around 15-20 years, there has been increasing interest in endoscopic assisted evacuations. The obvious benefit being you have a superior visualization of the entire cavity, and you can make sure you remove all septations and clear everything. And in endoscopic evacuation, again, people starting combining this membranectomy segment along with the endoscopic evacuation. We'll be discussing that further. And your other options are medical options, tranexamic acid and your AC inhibitors. And the recent one, your MMA embolization, which is gaining quite a lot of weight. And other one is the combination of various management approaches. Now, just discuss this membranectomy point. This is a review article on open membranectomies. Now, we earlier saw two review articles that gave recurrences in the double digits, and those articles at the most had limited membranectomies with incisions, small openings in the inner membrane. Now, again, this article, all these studies are extremely heterogeneous. The technique descriptions within each article is also different. The craniotomies where they have placed, whether they've cauterized the remaining are different. But you do notice a trend that you start seeing the recurrence rates coming in a lot of CTs in the single digits. And this is the largest series that I was able to find with 2,200 patients with just 0.4% incidence when he removed the inner membrane. Now, we'll keep that point on hold. So membranectomy slightly, inner membranectomy favoring a lower recurrence. Now, coming to the endoscopic point. So around 15 years, this also started gaining some weightage. And again, recurrence rates that were observed were again in the single digits. And patients tended to do well compared to your open techniques and blind burr-hole evacuations. Now, with this in mind, where your whether it's open or endoscopic, your removal of your membrane possibly reduces your recurrence, and a complete endoscopic visualization and evacuation also. So we wanted to combine this, and in endoscopically, instead of a craniotomy, just with a wide burr hole, or if occasionally when we get access to our medtronic drills and all, we put a small mini craniotomy. And here, when I mention membranectomy, I mean an inner membranectomy. In our series, we did not touch the outer membrane at all. So in this series, 19 patients with chronic STH were admitted during a span of 4 months. Their average age was 60 years, and most of them were males. And around 75% of them have, 73.7% of them have a trivial trauma history. 15.8% were on antiplatelets. And all the patients presented with altered sensorium and contralateral limb weakness of various degrees. Now, only 63% had a history of headache, and around 9% had a history of vomiting. CT was taken for all patients on arrival, and after taking an informed consent, we proceeded with endoscopic evacuation. There's one small thing I'd like to mention here. We always take a consent for a larger craniotomy if needed. So in the event there's a bleed that we're not able to control, a conversion is going to be necessary. And so all patients, we go ahead with a small craniotomy and membrane excision. We either use a frontal or a parietal small craniotomy. And your screen incision, we usual parasagittal linear incision or a slightly curvilinear incision. Now, the burr hole placement, like I said, when we have access to the equipment, which is not always, we can do a small well-planned mini craniotomy, which usually 2 to 2.5 by 4 centimeter craniotomy suffices. So when we don't have that, what I do is we put 2 burr holes adjacent to each other and then connect them. And a small point about these burr holes, the side towards which you want to put the endoscope, I usually bevel the inner edge so that the edge doesn't hit your endoscope and you have wider mobility. Like here, the burr holes were connected, and the outer edge I again used a craniotomy, thinned it out, the outer table on one side, and here bitten off the inner, nibbled off the inner table a bit more so that you have wider mobility. Now, I'd like just pick 2 cases for illustration. Now, this patient is a 56-year-old who presented with altered sensorium with right hemiplegia and had a history of fall just 2 days back. Now, you can see some acute blood here and a gradient type of chronic STH. There's also a bit of cerebral edema also. Now, I just show the intro video of this patient. Yeah. No, we've done the craniotomy, we've evacuated and mixed intensity acute and chronic blood has been evacuated. Now you see a thin membrane and it's already floating out. It's probably that the reason becomes obvious in just a second. That's the thin inner membrane actually. Now, as we suck, you can see a bit of piral hemorrhage that is already there. It's probably the acute trauma with piral hemorrhage has already lifted up the inner membrane. Now, this is a very flimsy, thin inner membrane. Like I mentioned, your gradient type of chronic STHs do tend to have a thin inner membrane. Now, this is when if comparatively a relatively easy chronic STH to do endoscopically. You remove all the septations, you remove all the blood. There's a lot of acute blood inside. And I just fast forward a bit. Yeah. And you see a lot of bile hemorrhage, and you gradually remove the septations. Now you can see that at the venous curvatures, you can see some adhesions between the fire covering the cortical veins and the inner membrane is lifted up and attached to the outer membrane. Most of the times, there's what we have observed is there's actually no bridging vein inside and just a fibrotic adhesion there, which sometimes can be easily broken off. But if it is very adherent, it's better to leave it alone. So you gradually progress, you remove it, you evacuate all the blood, break out all the septations. Now, yeah, like here, there was an adherence there. It was mostly fibrotic. We were able to gradually remove it. Yeah, that's the outer membrane you see there. You don't touch that. You leave it intact. So once you've done with your 0 degree, you can put your 30 degree scope inside. Go to your frontal and your parietal extremities and evacuate it completely. Now, there are patients who present with seizures, like I mentioned. Like you can notice here that your pia has become fibrotic here and there. There is some pial inflammation also in chronic. I don't want to go into detail with that. It's probably pointing towards something, but it's maybe it's an area that needs to be looked upon. Now, this is the post-op scan of the patient. Just this is the pre-op and this is post-op day 1. 24 hours, you have a nice brain expansion. This is the saline that you filled it with. And patient came for a 6-month follow-up and is completely asymptomatic to date. And this is the second case. You have a 65-year-old male, again presented with altered sensorium with a right hemiparesis. Now has a trabecular variant with significant mass effect and midline shift. Yeah. In this patient, we did not have access to a good endoscope, and apologies for the quality of the video, but if we can move past that, I'll just say that whatever the camera quality was a bit bad, so whatever pink area that we're seeing is actually red and bloody. So this patient had a thick fibrotic membrane. Like I said, trabecular chronic stages tend to have a lot of fibrosis, and it was quite tense. You can, it's very elastic, and if you lift it and you leave it behind also, it tends to just push back and hold the brain in place. So probably prevents brain expansion as well. So we've removed all the septations, we've removed all the chronic STH. We gradually excise the fibrotic membrane. As to how much we excise the membrane, we usually go till the edge where it curves and joins with the outer membrane, and at those points it starts oozing a bit. We don't go beyond that, and there are series where we use bipolars and cauterize the outer membrane. One point is that we did not have access to the endoscopic bipolars, but anyway, what we observed, maybe because of the lack of that, is that you don't necessarily have to cauterize all this outer membrane, because we did not observe any recurrence just by this. You'll see that the thick fleshy outer membrane is left behind, and we just remove the inner membrane. So a complete inner membranectomy was done. And this was on post-op day 1 itself. Significant expansion, little bit of pneumocephalus. This was at 6-month follow-up. So all patients improved post-operatively. Chronic STH patients, when done properly and brain is expanded, tend to show significant improvement within the first 24 hours. And they remain completely asymptomatic in the 6-month follow-up. And in 17 of these 2 patients, we were not able to take a 6 month CT because of logistic reasons, but remaining 70% did not have any reaccumulation also. And apart from the mild surgical side pain, there were no complications. And points to note, this is a very preliminary series to come to any meaningful conclusion, but the technique is extremely variable. Even my professors used to say that a simple burhole and the continuous irrigation is enough. But we because of the recurrences only, we had to go for the study, and the lack of recurrence in our series may be because of the membranectomy, or just like those professors said, because just with meticulous evacuation also, maybe the recurrence was low. Needs to be explored. And one of the main things one of my professors said about removing inner membrane was the seizure risk when you remove the inner membrane, but we did not have any seizure, post-operative seizure. For our patients, we gave a antiepileptic prophylaxis for 1 month, then tapered and stopped. None of them had any seizure in the 6 month. Actually, to date, none of our patients have had a seizure. Probably because the IR still intact, needs to be explored with the larger series. And based on this series, we have actually registered an RCT and it's still ongoing. So hopefully it will shed some light. This is our team, sir. Thank you.
Thank you, Dr. Priyadarshan. So the house is open for the question.
Thank you very much. Maybe we can have a comment by Ashish first. Then
Thank
I'm
you.
sure there are many questions I also have.
Thank you so much. Very interesting way to treat subdural hematomas. I think the major problem, in my opinion, when it happens during the surgery is like why I moved from burr hole to mini craniotomy for open evacuations is basically because of the recurrences. And you know, giving a keep enlarging your burr hole so that you can actually use your bipolar and micro scissors to go in the cavity and kind of, you know, cut down all the septations to make it into a single big cavity is the goal of my surgery. So when I now see, earlier I started with burr holes, then mini craniotomy in the standard area, but now I use navigation to go where it's most difficult to open up, where I see maximum trabeculation and septations, and then I open that area. But I agree, like, you know, at certain point of time you have to stop because you are physically, you know, it's difficult to reach out to the corner. So I think that's an excellent way of reaching out far, deep, and you know, very, very, you know, go around the crevices and the corners. And I could see, like, you could actually go under the, like, nearly reaching the skull base as well. So I just wanted to ask, like, the advantage is obviously, you know, your access. It gives you a great access elimination, and you can see. Do you find it challenging sometimes because without the bipolar, or because of without any like endoscopic hemostatic techniques, is it difficult to control if suppose there is a oozing or there is some venous oozing while you are manipulating these membranes? Because sometimes you can have this plane in the inner membranes, sometimes you just have septations. So normally, like, I avoid going and stripping the inner membrane off because it will cause more bleeding, and I do not have control from a small craniotomy. But probably, you know, with endoscope, you can have control, you can see, and you can coagulate if you have bipolars. Just wanted your thoughts on that.
So I've not included the patients that are currently in our RCT because, and till now, whatever I've done and whatever I've seen, even my professors were also a bit surprised on this. We did not ever have to use an endoscopic bipolar. The inner membrane lifts off quite easily, and in 2 cases I had to put a catheter under, put some saline irrigation, but it does lift off very easily. And as long as we don't injure the pyometer, I've not seen a surface bleed. And like I said, like you said, like there is always a risk of bleed. So especially at those cortical veins where they've where they usually tend to be adherent. Now, because I did not have access to an endo bipolar, never attempted. Whenever it is very adherent, very thick, I just leave it alone. Now, but let's just, like, around 70% of the time, those other sessions are quite flimsy, and just by mild manipulation, it breaks off on its own. And whether we need to remove those adhesions, we'll have to look upon. But never had to encounter. I've never had a situation where I had to convert it into an open craniotomy. It always one time maybe the individual investigators' meticulousness actually matters here a lot. My colleague tried the same endoscopic membranectomy once. What happened was, towards the region where it connects with the outer membrane, he was a bit aggressive and it started bleeding, and it recurred. but even in the recurrence, I had to go in. I used an endoscopic technique only. It was just a mild dose. He gave a thorough wash. It resolved again on chin. I don't think it's that technically difficult, sir. And initially it took about an hour for me to finish this, but now it takes a routine Burholz time only. About half an hour we're able to finish it.
I mean, I think I'll have to check, but usually what happens is if you just remove the septations from the outer membrane to the inner membrane and make it into a big single cavity, I think it works most of the time, at least in my hands. But I like to just mention about the embolization trial because there is a lot of interest in that. So I'll just briefly mention that. So there have been 3 RCTs which were actually showcased and discussed in the International Stroke Conference this February, like last month. And there is a big interest amongst radiology, our radiology colleagues, that you can use subdural hematomas and you can treat them with endovascular embolization. So they started with like treating asymptomatic ones, small subdural hematomas presenting with headaches. But with these 3 trials, what they have actually done, they have tried on embolizing the middle meningeal artery in recurrent cases only. So they found that like in recurrences, it helps. And that's my observation also. So if there's mass effect, if there's anything which is causing neurological compromise, obviously surgery becomes the first choice. Even during the second, recurrence, I still prefer taking the patient to the OR because it's that easy. Sometimes some patients, around 20%, will need repeat evacuation. But if there is a still recurrent, for the third time there is a recurrence, then what I usually do is I take the patient to the OR, evacuate it again, but then take the patient directly to the angio in the same anesthesia and embolize the MMA. So, but again, like I think with these 3 trials, which are considered landmark now, I think after the first surgery, more and more people will go and take the patients to the angio cath lab. Do you have any access at your hospital there where your endovascular colleagues are excited by this?
So we don't have access to that, but I have a friend who's very big on this embolization. But like you can probably guess, the main factor is cost. It's even the cheapest, even if a company donates or something, it takes around 70,000 rupees, which is like, okay, $700. And Indian population, that's probably their yearly salary. So yeah, that's a main factor. And your recurrence points, even not included it as an exclusion factor in our RCT, it's included, showing good results with endoscopic. I would expect it to complete in another 3 months. Probably will, and definitely cheaper than MMA embolization. And MMA, I don't have any experience, but my understanding is it takes at least a month or 2 for the resolution to come, and your clinical improvement is also gradual, to my understanding. Our patients, the improvement, like I said, occurs within like 24 hours and it's sustained.
Yeah, so what I was saying is basically, we have moved from using MMA embolization as the primary modality from that position to a position where we use it as an adjunct. So when you use it, you do it after the surgery. So the improvement will be after surgery and due to surgery, but the recurrence will not be there, so that you don't need to operate it again and again and again. So the improvement happens due to surgery. MMA is basically a prophylactic step to make sure you don't have a second or a third recurrence. But that's where there is a divide between surgical community and endovascular colleagues. But anyway, great presentation. I think your RCT will be very, very useful. There will be some of them will be saying like, oh, why I can do it surgically. Question is not that whether you can do surgically or not. Question is that whether you can reach out and to the corners and to the to have a deeper access. And I think Alberto has an experience with flexible endoscopy, so maybe that will help more, and he can talk about it in detail. So great presentation, great job. Thank you. Oops, sorry.
Yes, so I think we have Dr. Biswas.
Thank you, sir, for interacting. Great presentation. I have one question. Was there any recurrence in endoscopic membranectomy? And in case of recurrence, what was your approach? And this number one. And number two, as Ashish sir is here, so any experience of MMA embolization, especially in case of recurrence, or what is the protocol of MMA embolization? Is it on first time or in case of recurrence case? Thank you.
Yes. First of all, defining recurrence in these cases. It's again a clinical radiological. As long as asymptomatic, any lesion, yeah, even if it's a rebleed and if it's not causing any symptoms, we tend to leave it alone. So when there's a clinical, in my series or till now, we did not have any clinical radiologic recurrence. So yeah, and next MMA embolization, I don't have any exposures.
So I just mentioned that I was talking about that only. We usually do not do MMA embolization because one, it is like it's not like completely risk-free procedure. You have to go through the MMA, make sure you are beyond the ophthalmic branch, and then we embolize it. And it's like a lot of work for a thing which you can easily do surgically. Like, there is always this balance. But if you are operating on a recurrences, so my threshold, as I said second recurrence. I even don't take the patient down for angio, even for the second recurrence, because even the second time you just open the flap which you already opened and just evacuate it again. But if I'm operating after that second recurrence, if it's patient still developing, as I said, like not all fluid needs to be drained out. If there's a clinical, deterioration happening over the period of time, I will go for the third evacuation very, very rarely. And that's why probably I've done 4 or 5 embolizations till now in like so many years. It's not very common because none of them will reach the second recurrence stage. And then if that happens, we take the patient, make sure that we evacuate first to make sure that the surgery helps, and then take the patient in the same anesthesia, book the cath lab, and then take the patient down and do the MMA embolization for prophylaxis. So post-op CT will look great, but I've seen after 3 months, 6 months, it never comes back. So it is effective. It's just like when you want to use it, that's important. Some people may use it after recurrence. That's what I'm saying, that these 3 trials which came in, they are like RCTs, and they're studied now that if you do it for recurrences, they do not come back. So it's a very promising result.
Yeah, I have the same attitude.
Thank you, sir.
I have the same attitude. Usually we do bar hole surgery, evacuation of the chronic subdural. We do it in local anesthesia, though. Basically always in local anesthesia, so very minimally invasive. And we use the embolization only in those cases when we have like recurrence after a couple of bar hole evacuation. Yeah, same. We have Ben next.
Yes, thank you. Again, great presentation. I also have a little experience using endoscope. There are 2 kinds of endoscope that I think is helpful. One is the endoscope with variable degree by Storrs. So you can switch the angle, and because sometimes the burr hole that I try is an ordinary one, that is a small burr hole that you can view with variable degree and inspect without putting the shaft too deep. And another one is using a malleable shaft. The resolution is not good. It's not that good as a conventional endoscope, but still, it's the malleable nature making it easier to use during the surgery. So my question is about in your series. So still removing the inner membranes make me feel sometimes dangerous because of the adherent nature of those cortical wings. So is there any difference in recurrent rates in the patient with and without removal of the inner membranes? So do you think, is there any clinical differences? And also, how about the operative time? Usually, how long it takes for you to remove the inner membranes? And would there be any assistant holding endoscope for you? Yes, thank you.
Yes, sir. whether or not to remove the inner membrane. Like I said, sir, it's a very small series. It's too early to come to a conclusion. We're not sure whether just the meticulous evacuation alone leads to a good outcome, or the inner membrane actually contributed to the outcome. You need a larger volume and a control series to say something definitive. We're working on that, but looking at the trends, it probably suggests towards that. Again, nothing definitive. And on the time, the first time I did it very slowly. So I was very careful. Like I said, I did not have an endo bipolar. I took around 1.5 hours. And now it's become a routine for me. I'd finish it in half an hour. And the equipment wise, no one holds my endoscope or my instruments, and I don't put it on a stand either. We place the patient the head in a lateral position so that it's parallel to the floor. I like to stand and have both the instruments in my hand with adequate control. And as my instrument moves, I move the scope along with it, but I get as much magnification where I'm removing as possible.
I see. Thank you. Thank you so much, and congratulations.
Thank you. Dr. Afzal?
Thank you.
I think we cannot hear you very well, Afzal. Not so clear. I don't know if it is my problem or do you guys hear?
No, we can't hear him.
No, actually, you have some connection problems, maybe.
Right.
Problem is,
You can type your question.
Yeah, you can write down your question maybe. And while you write down, maybe I also can comment a bit about this presentation. It was very nice presentation. Of course, I enjoyed it. It's a endoscopic procedure. Endoscopy is something cutting the edge nowadays. Usually, we do, though, as I said, a single bar hole evacuation in local anesthesia. And in our experience, this is effective in the majority of cases. I would say more than 95% of cases can be fixed with just one single operation in local anesthesia and one bar hole. I used the endoscope to evacuate chronic subdural and also a couple of acute subdural in very old patients who couldn't undergo craniotomy. But if we talk about chronic subdurals, I use the flexible endoscope in case of recurrence. So I think your study is a great study, but there is a bias. You said you have 17 cases, all brilliant outcomes, but you might have had the same brilliant outcome with a simpler operation in local anesthesia. So I think you should focus on recurrent cases using the endoscopic procedure and see whether the endoscopic procedure can avoid a third operation. That would be very convincing, I think. And about the inner membrane, I never touched the inner membrane. I think there are more dangers than benefits for the same reason I said. You don't touch the inner membrane, and in more than 95% of cases, you have no problems. But I have to admit that if you have direct vision with the endoscope, it might be safer, maybe. And last point, the cases I have performed using an endoscope, as Ashish mentioned, I operated them using a flexible endoscope, quite big, I have to say, 5-6 millimeters diameter, flexible endoscope. So I placed the bar hole as usually placed in the same position, not any problem of, having the bone hampering your movements because the flexible scope is flexible, so you don't hit the skull. I understand flexible scopes are not so widespread like a rigid endoscope, of course, but it's a very nice instrument, very user-friendly, I think, and much easier to perform this kind of surgeries. But I want to congratulate because you are doing a very good job. So let's see if Afzal fixed his connection. Can we try again?
Can you hear me?
Try to speak. No way.
He has actually typed in the question.
Yeah, type the question on the chat.
Yes.
Type the question on the chat, please.
Yeah,
we cannot hear you well.
He is saying that, Afzal is saying that I just wanted to add that in our center, we always embolize patients with chronic subdural hematoma without neurology in local anesthesia. The results are very good. And in patients with deficits, we operate and do a repeat scan after a few days in case of relevant recurrence. Also with our neurology, we embolize before we discharge the patients. He's saying that they are embolizing patients in those cases which are without neurological deficit in local anesthesia, and those patients who are having neurological deficit after evacuation, they do embolize.
I see. Yes, it's as Dr. Priyadarshan said, it's a very variable, field. We all use some different techniques, slightly different techniques. Ashish.
So, so I wanted to ask Afzal. It's unfortunate that we cannot hear him, but Dr. Afzal, like this is where there has been a lot of controversy. For example, if there is a 3 millimeter, 4 millimeter, 5 millimeters subdural hematoma, would you still go ahead and do the embolization without, if the patient is even not having neurological complications or sequelae? That's something which is important. Or you are talking about those patients where there is significant midline shift, but they are neurologically intact. So these are the two different things which we are talking about. And I think it works very well in recurrences. There's no doubt about it. Whether you want to do it in the first recurrence or the second recurrence, I just think like more the procedure, more are the, try to keep things simple. So for third recurrences, yes, I will definitely do it after evacuating it. I wanted to ask one more thing, Alberto, like if suppose you see a lot of trabeculations, a lot of septations, burhole, like, which area you will do the burhole? Do you think that, it can be, there are a lot of chances of recurrences if you see multiple trabeculated subdurals? Because you can't cut them with a burhole, right? Like you cannot.
Yeah, of course. Yeah, actually, this is another case when I use a flexible endoscope. So the bar hole is placed at the level of where the subdural is thicker, basically. And then if preoperatively I see there are many trabeculations, I can enter with the flexible scope and fenestrate the septa, and make all the chambers communicating one with the other. So making the evacuation easier through the same local anesthesia.
So in that case, also you do local anesthesia and use
yeah, absolutely. Because of course, if you use a rigid endoscope and the patient moves his head, that's dangerous. I would not use local anesthesia with a rigid endoscope. But as I'm using a flexible endoscope, if the patient moves the head, nothing will happen. The endoscope is flexible, so no problem.
Amazing. Thank you.
Afzal, probably.
I only heard part of the question. Do you hear me now? No.
I think much better now.
Much better now.
Oh, that's nice. Okay. Anyway, the thing is, you're asking me what do you do for subclinical chronic subdural hematoma. So we also don't like if they are like very small, we don't go in, but we do repeat come in a couple of weeks or 2 weeks or 4 weeks. And if it shows significant progress, we do like talk to the patients and offer them embolization even without neurology. That's the first part of that's what I mean.
Thank you, Marcel. Issue, do we have other questions?
Prashant Chauhan. Prashant Chauhan. Yeah, you can ask question.
Good evening.
Maybe we have to allow. Okay, wait. Yeah, he can talk, I think.
Yes.
Good evening, everyone. Can you hear me?
Yeah.
Yes.
So in elderly patient, where there is because of the chronic, because of the atrophy of the brain and the chronic subdural hematoma is there. If after multiple drainage of hematoma, if there is a recurrence again and again, we have seen at least 3-4 patients where patient had required evacuation for hematoma at least for 2-3 times. And patient was out of the option of giving steroids or tranexamic acid or maybe MMA mobilization also. So in such cases, what are other options which we can try? Thank you.
Sir, can you tell what procedure you actually did for the patient? Like you mentioned
It was
recurrence.
the Burrow evacuation with drainage, with drain, Jackson Pratt flat drain.
Yeah, that's what, sir. During my residency, I had these problems. My professors consistently say Burrow evacuation is necessary, is enough, nothing more is needed. But I've faced situations where 2 Burrow evacuations, 3 Burrow evacuations, no brain expansion. That's why we moved on to the endoscopic, and it's included in our CT. Probably will shed some light on that.
Okay, thank you.
I mean, endoscopic probably could be an answer for the recurrence issue as well.
Thank you.
We think that if that facility is not available, then what we can do? Like you are having basic facilities, working in a periphery.
Then probably a craniotomy, and if the patient is fit for GA.
So in all these patients, there was no clear, the coming out fluid was completely clear. Next day CT scan was showing clear, there was no hematoma at all. And maybe later part after a week or 15 days or so, if we are doing the scan, they are showing the recurrence.
That I've not faced. So what I was saying was the non-brain expansion at all. Once it resolved, I've never faced a situation where it keeps coming back.
Maybe
more experience, probably. Yeah.
Maybe Ashish sir or Dr. Kato can suggest something, or Dr. Alberto Ferretti.
Yeah, you mean in cases when you have recurrences?
Yes, for recurrences.
Yeah, as I said, usually we have this kind of workflow. First, single bar hole in local anesthesia. If there is a recurrence, we redo surgery with the same bar hole, eventually using a flexible scope. If we have another recurrence, but this happened, I think, just a couple of times, then we go for meningeal artery embolization. And in those cases, very few, as I said, couple of cases, after meningeal artery embolization, the problem was fixed and the patient had no more recurrence. But as Ashish said, this procedure, embolization, is not with zero risks. There are some risks, especially for vision. If there are, sometimes there are some connections, arterial connections between the middle meningeal artery and the inner vascularization of the brain. So the neuroradiologist must be very, very, very cautious when performing this kind of procedure. But in selected cases, it was very effective.
Alberto, no, thank you, Dr. First, Dr. Johan, your question was that if those facilities are not available, then
Yes.
first, Dr. Alberto, you are talking about ideal situation where everything is available. I
Yeah.
think for such kind of cases, you can do mini craniotomy and stripping of the inner membrane, because that is the possibility which you can offer in a peripheral center where those facilities are not available. And if you want to dig further, then you can make large craniotomy and coagulate the superficial temporal artery near its origin from the foramen, I think rotundum, because it's coming out through the basal part of the temporal dura. You can coagulate there directly and prevent the recurrence. It's a
So,
big,
yeah,
not a big procedure.
so for all these patients, there were no membranes at all. In fact, the brain which was visible from the burhole, it was completely clean, and the returning fluid, everything was clear. Still, patient had a recurrence. So maybe the answer is endoscopy, maybe.
Yeah, you are saying that they developed subdural hygroma. That means they didn't
No,
develop
no, they have a clinic, means clinically also, and on the radiography also, there is a recurrence and patient was symptomatic for the.
But did you do craniotomy in this patient?
No. We, for the large, usually we do frontal and parietal two burrows. And
Okay,
connect
because
the
I
both
agree with issue. We also in the past used to, in those cases, we used to convert into a craniotomy. If you have many recurrences despite the barhole surgery, before starting with this flexible endoscopy and embolization, we also did craniotomy in those cases. So larger craniotomy, and you remove all the membrane remnants. This usually is enough to reduce the recurrence.
Okay, thank you.
Dr. Chauhan, I'll just add one more thing. So I used to do burhole, but I moved to mini craniotomy, measuring like around 3 centimeters for every single case. For just this reason, because most of the times, as I said, like local anesthesia, burhole will suffice. But if I see, so I do burholes only when I see an isodense layer and I see no trabeculations. If you see isodense subdural on a CT, that means there are no trabeculations. Anywhere you do a burhole, you irrigate well till the return is clear, and we leave a drain for 24 hours. And that's again a controversial topic. Some people use drains, some people do not use drains. But regardless, if it's isodense, I use burhole. But if there are any trabeculations, I'll try to use navigation to open in that area and do a mini craniotomy so that I can cut down the septations. I do not touch the inner membrane, as Alberto said. I'll just cut down all the septations, make sure it's a big single cavity, and I'll drain everything till the return is clear, leave a drain and come out. So this way the recurrences have been less also. So this you can do at your place too. Like you just do a mini craniotomy, 3 centimeters, go a little wider than a burhole, and do it under general anesthesia if there's a recurrence, and try to cut all the septations which you see. Maybe it will not recur. They still can recur, I think, but still hopefully like less recurrences.
Yeah. So Dr. Ashish sir, so I'm working at Bombay Hospital only.
Okay.
With Dr. 𝒂𝒏𝒊𝒏𝒊, Dr. Sunil Shah and all. So in one of their cases only, and Sunil Shah sir and Dr. Nirav Mehta's cases, this kind of complication we have seen. So we have tried almost everything. Maybe in one case we have done a mini craniotomy, but other patient on the follow-up there was a bleed, but I could not do the follow-up for that patient. What exactly they had to do. So that's why I had a question.
What was the age of these patients where you had recurrences?
These all patients were elderly, maybe around 75 plus.
Okay. Okay. Well,
okay, so we gave you some other options. I think we have to move on because, of course, first we have to thank both speakers today. Great talks, great discussions. Thank you, Ishu, for co-moderation. Thank you, Ashish, for your comments, and also thanks to our discussants. But it's time now to move to the introductions from the current fellows at Fujita Bantane. So I kindly ask the new fellows to shortly introduce themselves, tell us where they come from and what they are doing. Maybe Biswas the first? I don't know how many you are.
Okay, can I share slide?
Of course.
Unable to share. Am I allowed to share?
I think you are allowed to share.
You can try now.
Yeah, you should be allowed to share. Yeah.
My slides are visible, Professor?
Yep.
Okay. Konbanwa, Sensei Yokokato. Good evening and good morning, all the attendees, professors. Thank you for the opportunity for my introductory presentation. Myself, Dr. Mohammad Shahnaz Biswas. I'm a present Fujita Fellow at Bantane Hospital, Nagoya. I worked as a neurosurgeon in National Institute of Neuroscience and Hospital, Dhaka, Bangladesh. I came to Japan from Dhaka, Bangladesh. I graduated from Dhaka Medical College Hospital. It is the largest hospital in Bangladesh. I completed my post-graduation in neurosurgery from Bangabandhu Sheikh Mujib Medical University. It is the largest university in Bangladesh. And presently, as I have said, I'm working in National Institute of Neuroscience and Hospital. It is the largest center of referral of neurological and neurosurgical cases in my country. For my residency, I dreamed about being a hybrid vascular neurosurgeon, and I worked thereby accordingly. This is my sensei back in my country, Professor Dr. Mohammad Shafiqul Islam, the #1 hybrid vascular neurosurgeon. Thereby, I had a great opportunity to being exposed to varieties of vascular cases, clipping, microvascular decompression, and bypass as well. And these are some cases of clipping cases, ecom aneurysm, the IC terminus aneurysm for clipping. This is the carotid cave aneurysm. We did clipping, and the endovascular exposure. I had a great opportunity since my residency of 5 years and 1 year of neurosurgeon plus 1 year of doing procedure, DSA spinal and cranial DSA procedures like clipping, coiling, AVM embolization, and CCF. Very few mechanical thrombectomy and flow diverter. This is the case of stenting, of IC stenting we did back in my country. This is a giant ecom aneurysm we did coiling successfully back in my country. This direct CCF. It was a very nice case. We did use for about 35 coils, and then we have a great team back in my country. The for endoscopy exposure, cellular, supracellular, as well. This is like period giant microadenoma, craniopharyngioma. And we work with Fujita fellow Dr. Atik and Dr. Farhad. We have a great team for endoscopic cases, these microvascular endoscopic decompression of the trigeminal neuralgia. And keyhole approaches we learned from Takio Goto sensei. We did successfully. And this is the bar hole with endoscopic evacuation of the ICH. And we have a great exposure in trauma because Bangladesh is very prone to neurotrauma cases, all type of neurotrauma cases there. These are few articles, especially the endovascular articles I have written. Very rare few cases like vascular hydrocephalus and all the vascular causes of proptosis and conus AVM fed by artery of Des-Forges Gauthieron. Very rare cases. These are some articles I have published. I have done thesis on decompressive craniectomy versus sternostomy in traumatic brain injury. These are few of recognition of my work during residency life. Now, this is international exposure. I joined, attend 2018 Link seminar in Singapore, and we had a hybrid vascular session in Bangladesh in 2023. And with Gautam sir, we have endoscopy exposure. In Bengaluru, I attended the anterior skull-based program. Now, the transition at Fujita under the great guidance and affection of Professor Yoko Kato Sensei. Here we are having a great exposure, especially the hybrid vascular exposure, the endovascular under Tamura Sensei. We are watching 𝑇ℎ𝑒 𝐸𝑥𝑝𝑒𝑟𝑡, which are very rarely done in my country, but I'm getting great exposure here, especially the transdistal radial axis. All the procedure and diagnostic done here by the distal radial axis is a great learning exposure here. And doing vascular cases, microvascular cases like bypass with a small craniotomy. We went to Aichi Medical University, met Watanabe Sensei for the exposure to exoscope. We went to main campus Fujita. We had a great exposure of by Professor Nakahara Sensei for the endovascular endosaccular devices. And definitely Komatsu Sensei at Fujita doing great work with microvascular decompression, and we are learning the AMIRA software to actually visualize preoperatively which artery is compressing the cranial nerves. And daily we practice bypass at our office at Fujita. We do research work every Saturday. These are my teams at Fujita right now. We do research work. I'm doing 2 articles on STMC target bypass through mini craniotomy in chronic steno-occlusive disease, a case series I'm doing under the guidance of Professor Yoko Kato Sensei. I'm also doing one that is mini pterygoidal craniotomy in an innovation in clipping surgery in the era of endovascular treatment. Very small craniotomy with zigzag incision for MC aneurysm and for the ICA terminus aneurysm. And these are some meeting we attended apart from our neurosurgical practices. We are becoming a part of Japanese culture. Every week we have many parties arranged by our sensei, Professor Yoko Kato, and I express my heartfelt thanks and gratitude for that. This is the recent party. In this program, we saw a great Sano Sensei from our Yoko Kato Sensei, becoming a part of Japanese culture. And this is my short presentation. I express my gratitude and thanks for hearing. And my endeavor is to skill knife and catheter, as Professor Ashish Sensei said. It's very inspiring. So with this, I conclude. Thank you very much.
Thank you very much, Dr. Biswas. Maybe next one, Dr. Evelyn.
Good evening.
Maybe Dr. Biswas, would you like to stop sharing? Okay. Dr. Evelyn, can you introduce yourself in a few words? Thank you.
I have a problem. Is the next whether?
Yeah, okay. So we can first hear Dr. Chawan.
Yeah.
Okay, if you can briefly introduce yourself.
Yeah. Yeah, myself, Dr. Parsati Chauhan. I am from, just a sec, sorry. Can you see my screen?
No.
Okay. I'll just introduce myself. I am Dr. Parsati Chauhan. I am from Jalod, Gujarat, which is a rural area of Gujarat, India. I'm currently settled in Mumbai and working at a Bombay hospital. I've done my graduation MBBS from Baroda, India. Followed by that, I've done my MS General Surgery, then finished it in 2018, and done my neurosurgery residency from Bombay Hospital. Um, have been trained under the guidance of Dr. Dev Pujari, Dr. K.K. Turel, Dr. Mahesh Chaudhary, Dr. Sunil Shah, and Dr. Karmarkar, and Dr. Neera Mehta and Dr. Chandan Mohanty. Uh, uh, just a second. I have come here to during my residency, I've been exposed to the endoscopic surgery, basic endovascular procedure like DSA, and few of the therapeutic procedure done by the neurologist at our hospital. And I was interested in vascular neurosurgery from the very beginning. So I chosen to do the same and learn more about the vascular neurosurgery at Fujita Health University, Bantane Hospital, under guidance of Dr. Yoko Kato. And currently I'm doing research, and maybe I'll write a paper on a comparison of outcome between clipping and endovascular coiling in anterior corridor artery aneurysm, and comparison of woven endobridge versus other method of endovascular treatment for wide neck bifurcation aneurysm. Thank you.
Thank you very much, Dr. Chauhan. Let's see if Dr. Evelyn fixed the problem, or in any way you can introduce yourself, Dr. Evelyn.
Can you see?
Please go ahead, Evelyn.
Okay.
Just a few words, enough.
Can you share it? Can you see?
No, we cannot. But if you have these technical problems, just introduce yourself by words.
Okay. Good night, everybody. It's a pleasure for me to belong and present myself. My name is Evelyn Vela. I was born in Peru, where I studied medicine 7 years, and then neurosurgery for 5 years in Peru. I worked 1 year as a general neurosurgery, 1 year. My inclination for a vascular neurosurgery led me to go to Sao Paulo for I take a fellowship vascular neurosurgery and microneuroanatomy in UniFESP with Professor Fershada. He transmit for he's a person very passionate with microneurosurgery and neuroanatomy. And when I returned to Peru, I worked in the institute, the National Institute of Neuroscience in Peru, in the area of vascular. No, in the institute have problems with the patient, have a long list of rupture and arrhythmia, waiting for surgery. No, we have for distribution of the resource for vascular and endovascular case, no, and a few and have a few hospital beds. I think a solution I found in Fujita, no, with Professor Kato. I need to learn minimal invasive techniques and that are safe with a short hospital stay for the patient. No? In the time and stay, I stay here. I have learned a lot of training with bypass, many case of endovascular and case of school based. No, I'm grateful with Professor Kato for all opportunity. No?
Evelyn, what is the paper plan? Evelyn, so what is the paper plan? Evelyn, can you hear? Yes, what is the paper? Research plan.
My research plan is to learn techniques about minimal invasive. For I continue to teaching the residents in my country.
Okay, but you make a plan to write some paper about the radial approach?
Yes, I plan to write about transradial approach access and case of or bypass and mini-clearing approach. These topics is I like to practice in my country when I return.
Nice, very good. So we are happy we had the chance to meet the new fellows here today. I think we can close this Fujita webinar. Thank you to the speakers. Thank you to everyone. Maybe Professor Kato wants to give some conclusions.
So it's more and more the colleagues increasing the alumni members. I think they enrich their daily life, and also they are planning to go to the stroke meeting in this week. So it's one of the biggest meeting. I think they can have more knowledge from the meeting. So I think, and also I think chronic subdural hematoma, it was very excellent talk. I think the most important thing is how we can control the bleeding point. Sometimes we can see the bleeding point. So even the flexible or rigid. Sometimes passes, even we complete the elimination of the hematoma, but sometimes we cannot remove the very the end of the corner. So maybe such place, I think it will have some chance to recurrent bleeding, I think. So anyway, is a recent endoscopic procedure is, I think, much better than usual lumbar hole surgery, I think. But anyway, we had a very fruitful webinar today. Thank you very much, all your effort. Afzal, are you okay? Okay, thanks so much. Okay.
Thank you very much.
Thank you very much. Okay.
Thank you.
またね。はい。
またね。
またね。
Thank you.
また、おやすみなさい。
ありがとうございます。
Bye,
ありがとうご
Professor.
ざいました。おやすみなさい。
See you next time.
Next time.